Gordon.
Yes, Gordon.
Well, great. I think we have a quorum, so we can get started. So, hi, Gordon. Madam Chair, Pat, do you want to start with introductions and I'll just go around the screen?
Sure, it's Pat Kimball, retired chair of the committee. Loving the data that's coming up. I think Mary's been collecting some stuff in the last few conversations. I really think we'll put this committee moving forward. So thank you.
Excellent. Liz.
Hi, Liz Blackwell-Moore, she, her pronouns, and I am the Director of Public Health for Cumberland County Government.
And Chastity.
Hi everyone, Chastity Toole. I use she, her pronouns. I'm the Northern Maine Director of Harm Reduction Services at Maine Access Points.
And Gordon.
Gordon Smith, he, him pronouns. I'm the state's Director of Opioid Response. I just got a text from Bruce Nodden that he's having trouble getting into the meeting.
Miles just texted that he's stuck on the other side of Zoom.
Maybe that's Bruce's problem as well.
Then I'll keep going. Kim.
Kim Johnson, consultant.
Great. And I'm Joe Everett at the Opportunity Alliance in South Portland and chair of the committee. And Haley, I think you guys are doing, oh, there comes Miles. Good. One in.
Yes, we're all here together. Ella, Mary, Brendan, and I.
Perfect. Miles, we're just doing introductions. If you want to introduce yourself too.
Hi, my name is Miles Willett. I'm a clinical supervisor for an outpatient treatment center. Also a person directly affected by the opioid crisis.
Thank you. So as we welcome everyone to our meeting and have folks had a chance to review the minutes. And if so, I would take a motion in a second. And I think we'll have to do a roll, Haley, right?
I make a motion to approve the minutes.
Seconded.
Sorry, I'm just trying to send the link to Bruce.
Oh, no worries.
I think you have to be on screen to do it, Mary.
Haley, I had the same issue that I've had, but I managed to log into Zoom this time and make it all work that way. So
good. Yeah, if anyone has trouble with their link, just go on as a regular participant like Miles does, and eventually we'll notice you. It might not be right away, but I'm just sending Bruce that regular link and I'll promote him when he gets in here. Mary's gonna do a roll call though while I do that.
All right, how do I do it? Sorry.
You just go by their names and let them say yay or nay.
Okay, Joe Everett.
Yes.
Chastity Toole.
Yes.
Liz Blackwell-Moore.
Yes.
Gordon Smith.
Yes.
Miles Willett.
Yes.
And Pat Kimball.
Yes.
Great. Minutes approved. So thank you to Kim and Mary for the great information. And it might make sense, Kim and Mary, for us to pass the baton over to you guys to review your work, but it was really good. So I'll pass it over to you two for a discussion.
So I want to tell you how we came up with the list, because you might make some different choices, right? So that's the first thing. What I did was take the voting and basically took the two highest in the category. And some of the categories, it was easy. Everything dropped off after the top two. In harm reduction, there was a tie so I put them both on there. And in recovery support, there was one that was high up and then everything else was dropped off. So there was the one that had the 6 votes was the funding for the recovery centers, and then everything else was 2. So here's 2 things that you might want to think about, because I made a decision just to get you something and you might want to make a different decision. For treatment, the top 2 were the detox beds in the low barrier MOUD, but residential treatment came in 3rd with votes, so it was close. For recovery support, I made a random decision to pick two things and put them together because we had talked about that in the last big meeting. And so I just stuck two residential things together that really are very different, but I put them on there so you'd have two from recovery support. So you might want to make some different choices. You might want to look at recovery support and go through another voting process. You might, but I just, so don't assume this is your final list. This is just how I organize the voting stuff for you, and you may want to discuss that further and have us do more research on some other topics. So just, that I wanted to be clear about that. But then what we did, so we created these folders, and I don't know if Haley has been able to send you the Dropbox list or not, but just in terms of the evidence.
I have not distributed that yet. I was going to send it out with the meeting materials for next meeting.
Okay, so we have these folders with peer-reviewed papers and some other documents, like there are some SAMHSA documents. I have an a new ASAM document that's in the treatment version that are the evidence for these various practices. And I originally did that for everything that you were looking at, and then I've added a few things for these specific topics. One thing I want to say about evidence is sometimes there's no evidence because it hasn't been researched yet, or that particular outcome hasn't been researched for that particular thing. So just know that unless the evidence says you should not do this, it doesn't necessarily mean that you've picked something bad. If I say weak evidence because there isn't that much research yet, that means it's just because there's not that much research yet. So you'll get all those folders. I don't think you picked anything that there isn't evidence for, but I wanted you to have that. And then Mary had some conversation. So we really wanted to have you have a sense of dollar amounts so that you could think about, and I don't know if the finance committee is going to have this conversation. I don't know who's making the decision exactly, but I thought you would want to talk about today about, after we left the meeting last time, about sort of how much goes to what, or how you want to suggest distributing, what you do next. And so we thought it would be helpful to have some sense of the cost of things. One thing I think you may want that we haven't gotten for you yet is particularly on the things that the state has already RFP'd, what would be the cost of funding the next couple things on the list, right? As opposed to just the full amount. And so that could be something that would be helpful to you that we haven't gotten for you yet. I just threw in some potential outcome measures. I don't think we should talk about that now. That was me sort of noodling on how many of these actually get to the overdose death issue and how many are on mitigating other harms. And then Mary also got some stuff that she just got today, and so I think only sent to Joe and me, right? But you'll have it. That's what other states are doing on these particular issues and how much they're putting towards it. So that's what we did. Mary, do you want to add anything about about what you've captured in the funding part?
I think that covers most of it. For the current funding activity, that is inclusive of the information and data that I could gather. It doesn't include everything. So I'll continue to look into that and fill in gaps where I see it, but I just want to make that note. And if anyone on the council sees something where there is a current activity happening in that specific priority area, please let me know. But I just want to put that disclaimer out. And the costs that we included were primarily the costs that were associated with current funding examples or what we saw from other states.
Joe, I know Sheriff Brackett is being very polite and has his hand up, which is something I probably wouldn't take the time to do.
Mm-hmm. Yeah, Todd, go ahead. Sorry.
So I just had a quick question. I don't want to spend a lot of time on it, but or now anyway, but when the doctor refers to, when Kim refers to, best practices or practices, right? Evidence-based stuff, right? Are you referring to, when I think of evidence-based stuff, I think from my microscope, right? So in the criminal justice corrections field, right? When we do evidence-based stuff around recidivism, for example, there's a lot of information nationally on that topic versus information that's been researched here in Maine on the topic. And I know, so I just get a little confused over what we're talking about when we talk about evidence-based. I assume it's mostly national models, right? We haven't had a lot of time to study a lot of these things. Although some of these have been around for a long time, some of these programs and whatnot here in Maine.
Yeah,
Bruce will know what I'm talking about when I talk about recidivism and things like that.
So just to tell you sort of the process that I use, the first thing I looked for were peer-reviewed journals that were meta-analyses. So things that had more than one study, that were primarily clinical trials that you could say there were multiple studies that had the same outcome. So for example, MLUD has 50 years of clinical trials of various, the different medications. Or I think 50 years, it might be more than that at this point. So that's an example of, there's lots of evidence of a really good evidence that works. Some things work, but not necessarily for the outcomes so like some of the things that you identified were housing related, right? Well, there's a lot of evidence, for example, for housing first, for helping homelessness. The evidence for whether or not it addresses substance use disorder or substance use problems is really mixed and not very strong. So you fix the problem of housing, but it may not, which is important to keep people alive, right? That's an important mitigation of harm, but the evidence for addressing substance use disorders is not very strong. So that's the kind of stuff that I was doing. The first here is what's the randomized clinical trials in multiple trials, and then looking at are there any trials? Some things you can't study that way. Some things it's unethical to study that way. And so then looking at other kinds of research, and does the sort of the multiplicity of the different kinds of research still point in the same direction. And then some things are like BAR is an example. Maine was involved. There aren't peer-reviewed publications. Well, there are, but they aren't about the outcomes. But it was randomized, and it's written up in a report. And Maine participated in that research as well as other states. And so it's a big study. It's one study. It's not published in a peer-reviewed journal at this point, but there are reports on it that we had access to that, I read it and I say it's a good study, and it hasn't been published yet. So that's sort of the way I went through it. And there are some things that it's just, they're really like the recovery support centers. A lot of places are doing it. They're doing it really differently. And so trying to research that and say, what's the evidence-based practice? Well, the kind of research that there is not necessarily a randomized clinical trial on a specific model. It's really looking at who uses them and that kind of thing. So I say it's weak evidence, but that's just because of where they are sort of in their stage of development. And also the things they do are evidence-based. It's just the concept of how you put it together is not necessarily. So does that answer your question, Todd? That's basic.
That's helpful. Thank you. That makes sense. Thank you.
Any questions for Kim or Mary before we kind of dive into the... So do we want to just dive into the categories, sort of just have a discussion, maybe just following along as the way it's laid out, starting with treatment? Are folks just good with talking categorically? So starting in treatment, there were two, the high scores. One was detox beds and one was low barrier MOUD. Any further thoughts to guide the conversation?
So,
Well, I don't want to trump the chair. Pat, were you about to speak?
well, I was just going to ask the simple question was, I know that the RFPs just went out and the state is giving funds for increased detox beds. And so somewhere, and I think Kim brought it up earlier, I think for me, I need to ask the question, how many beds are the state intend to increase that by? And where in the state are those beds going to be located?
Do you want me to answer that now?
Yes, please.
Well, I can tell you what I know. There's also likely to be one more RFP, two, well, related, but two really. We've asked that they make every effort to get those out the door before our meeting on the 14th, so that we would be aware that the state has money to support those particular, they're both, well, one's related to beds and the other is related to not exactly beds, but certainly probably already said more than I'm supposed to, but the other might be related, might be related to like a crisis receiving unit, like the living room in other parts of the state. So I think probably we can, like I say, we've asked them to get that out because, like, again, it's important that you have that information. The and that RFP, by the way, is directly related to the piece of legislation that passed that directed OBH to do something in Washington County or Kennebec County and gave them just enough money to do one project. And there's been pretty much public comment that we didn't want those counties competing, that they both need what they need, and that we would try to come up with enough money to do both, and without recoveries, without settlement money. So that's what we'll hopefully have more definitive information for you on that. But there are some detox beds in that next piece. What we are already committed to and have out the door and have being worked on right now, and either have contracts for or tentative awards have been made. And I have, and this is all public information. We have the 10 detox beds by Wabanaki Public Health. I was on a call with them this morning, their bi-weekly call with the feds, and we're actually having a grand opening in December, but they expect to be open, actually have the beds open and the license and the staff all done by January. I would say they're probably open in January. So that's 10 beds. The Milestone project is about $2.1 million of state money. There's some federal earmark money too. They bought the property. They've contracted with that construction firm, French and Landry, maybe something. And the renovations are taking place. And while they originally hoped to open the new building, which will double the number of beds at this point to 30, eventually getting up to 32, all detox. That is, they hope to open it in January. I don't think that's possible, but I think it will be open by spring. So that doubles their beds. There are 2 detox beds for the first time in Aroostook County in Presque Isle. Those are already open, and there's a grand opening that Senator Collins and I are doing on Friday. And we're doing it together because the feds put in a big earmark for it, and we also put in $1 million, I think, as I recall. And then there's the Wellspring project that we're working on, and that would also about double their beds from roughly 10 or 12 to roughly 20 or more at a new building in Brewer. That contract's not signed yet, but that was the original plan, and they were conditionally awarded the contract. Pine Tree has 20 beds now available, detox available to Maine Care and uninsured for the first time on Bishop Street. So that's 20 new beds. So the way I add that up in my head, by spring, we should have 30, 40, 60, 82, plus what I can't announce, but you might see by December 14th. So that's, again, it's off the top of my head, but it's something that we obviously work on every day. I think it's the highest need in the state. I do. I think it's unconscionable that people who have made a decision to get better, if we don't have a place immediately to help them with that first step. It's not the only thing. We need a place for them to go after detox and all of that. But I think on the treatment piece, it's the first step. I think it's a very important one. And I think it will really make a difference when we start talking about 100 beds being available any given night and not 20 or 30.
Gordon, are there any places that you want more beds that aren't in your current plans?
Sure. Because of poor prevalence data, we honestly don't have a very good grasp on, well, how many detox beds do we need and where should they be? They don't really do waiting lists so much anymore. You're expected to call every day and see that there's a bed. So it's very complicated. But I mean, I think any geographical region in the state where there are none, would be a high priority. We've been working on a project in Androscoggin County to not have detox beds in Lewis and Auburn, even though, yeah, okay, it's a shorter drive to Milestone than it is from Machias, but really we certainly need something in the central Maine, in the Lewiston, Augusta area. Absolutely need detox beds in that area. And then really, I look at Miles, as I say, that's, 2 beds in Washington County. It's better than 0 beds, but no, it's nowhere near adequate. And in Western Maine, not much available. Somerset, Piscataquis, Oxford. So I think, Kim, in the rural areas, so I guess the short answer to your question is that absolutely we are not done. I've asked some providers, should we be worried that we're going to have too many detox beds and they'll be empty? We hope to get there. Nobody thinks we're even close yet. And I agree with that assessment, but that's not based on hard data. It's based upon anecdotal data that people can't get a bed, and parents calling the governor's office and making 25 calls to people. Now, remember, we have 33 hospitals that have the medical expertise to do detox, but we only have 2 that are licensed to actually have detox beds, and that's Penn Bay and St. Mary's. St. Mary's recently started detox for adolescents, and I couldn't have been more excited about it. That is a real good thing for them to do. But so we don't want to forget and just kind of leave them off the hook, because they are, if not a critical, you can't really talk about anything medically in the state, not think about the 33 hospitals that we have around the state, and their obligation as nonprofit community providers to do a community assessment and take care of the problems in that area.
So it sounds like in terms of the beds, and Gordon, you've talked a lot about residential beds. These are detox beds only, correct?
I'm only addressing detox right now, Joe, that's right.
Yeah, and the 10, I'm putting words in your mouth, so feel free to stop me, but the crisis centers, has money been appropriated to do to the Washington, the Kennebec? If it's the crisis center, I know you're talking, it's not public knowledge yet, and you don't have to answer that if it's not public, but I think I'm just trying to think about sort of the next steps in terms of the urgency of these projects.
Well, I think because the legislature directed the Office of Behavioral Health to do RFPs in Washington County and in Kennebec County, or in Kennebec County, and that they've expressed an intent to try to do both, that that likely they're trying to do that. I'm not at liberty to say more than that. But you can see our dilemma. That's why we very much want to be able to have that out the door by December 14th, so you'll know exactly what the state has committed its funds for.
And are you saying the award will be announced by then, or the RFP
No,
document?
no, but what you would know is how much money the state in
Yeah.
either our federal funds or general fund
Yeah.
are how much we're putting. The legislature, I think, put in about 3.1 million for one of the projects. So you can assume that we'd have to have $5-6 million probably to do both. Don't quote me, and those numbers could be a little off, but they're both a substantial amount of money. Yeah. And one is not bad. One likely wouldn't be bad. So.
Right.
And some decisions have to be made. Which county gets what.
Right. Right.
But I think, again, people working very hard on that. And I think there's a good chance, even though it's only 2 weeks from now, that we'll have the RFPs out the door. People be working on their applications by the 14th, I hope.
That's awesome. Great. So is there work to be done for our Mary, Kim, like around, and Gordon, around sort of when you talk about sort of the counties and what capacity is needed? I mean, not to step on the toes. I mean, if OBH is doing it, but I think what you're saying, Gordon, is dead on, that 2 beds here and there is not really enough. So I think the council seems very committed to this, but would you advise us, Gordon, to get more information as we think about helping to fund these beds? Or is that information available?
I think that people should absolutely be pressing the data people for the kinds of data that you need. Sometimes the data is just not available, but on the very next question of low barrier MOUD, for instance, I've asked the data team that I said, we know we have buprenorphine, because this just as an example, we have quite a bit of low barrier MOUD available. Miles and I have talked about this. I mean, it's probably one of the more substantial things that's been accomplished in the last 4 or 5 years. And partly that's the new organizations like groups, like Savita, like Better Life Partners, and also more primary care physicians, getting rid of the federal waiver, MOUD, low barrier access in probably 25 of the 33 emergency departments. So I don't know how high a priority I'd give on that, but I wanted to see by county, what is our per capita prescribing of buprenorphine? Because I've never seen that. So are we the best in the country? And if so, are we the best, assuming that more buprenorphine is a good thing, and that the higher per capita, the better? How are we compared to New Hampshire? How are we compared to nationally on that per capita? I've never seen such data, but I know it's available because we have it in the PMP and we have it in Maine Care data as well. So I think that the council should, we're not going to be able to have our own robust data collection and analysis and analytical department within the council, I suspect. So we should feel comfortable to asking the data people at the Office of Behavioral Health, gee, we'd like to see data on X. And then on the low barrier access to outpatient MOUD, we have good data on methadone, by the way. We have about 5,000 methadone patients, and it's growing slightly every month. And we're up to 14 facilities with a new one that opened in Rumford this month. It's really buprenorphine, you know, because it can be prescribed in a doctor's office, obviously. That there's a lot of it, but there may be some deserts in the state, some parts of the state that really are underserved with respect to even outpatient. So I think that should be a data-driven decision. And then the next thing really that we probably would want to talk about is just that third issue of residential treatment, because these are all difficult decisions, because once a person gets through their detox, we've said how important it is to provide a continuum of resources from help with withdrawal all the way through to recovery residence and employment. But that residential piece, we don't have enough residential beds. We have Catholic Charities, we've got some Wellspring, some Crossroads. Bella's house is closed right now in Springfield, but we're trying to keep it going. But I don't think anybody would suggest that we have sufficient residential beds.
Exactly. Go ahead, Bruce.
Yeah, and I'm looking at the low barrier MOUD. I'm just asking the question, are we considering incarceration a barrier? And I'm thinking specifically about jail, in expanding the availability of MOUD in jails. You know, across the board, there's no consistency from county jail to county jail. And obviously in some counties, they're limited to ridiculously low numbers of folks that they can serve. So I'm just wondering if we can stretch that, or if we are stretching at all when we look at low barrier MOUD, can we look at jails?
Well, I would hope so. And it raises another issue, and that is how many forms of MOUD. If the goal in our plan, in the governor's plan, our goal is that every patient with a substance use disorder should have an opportunity should have access to all forms. That would be methadone and 3 or 4 different forms of buprenorphine, and abstinence treatment if that's what they want. So, and Sublocade's very expensive. We have the pilot project in Somerset County that we've given $1 million for, but it's also had fantastic results. So I do think that enters into it as well. And you're right that I should have mentioned, it's not just geography that maybe we need more in Piscataquis County. It's also in our plan, one of the focus populations are people who are in the custody of the state or the county, and they have a substance use disorder. We believe they have a constitutional right to be treated with any of the 5 forms of MOUD.
But just so you know, the way that the thing was written is low barrier MOUD, all options across the state, especially for rural Maine. So that's what you voted on, which could imply everything that you're talking about. The other thing I thought about is sort of putting it with because you have the mobile units for harm reduction. Mobile units can do a lot of different things, right? And they could do harm reduction and treatment as well, if there are areas that you were thinking that it's actually hard to get. Gordon, can the PDMP data be mapped? Could the department do that? Was it map where the prescriptions are?
I think by county, they probably can't get it down to municipality, but I think they could do it by county. Some of these would require a little work, but and again, it's all de-identified, so it's not really a big. Well, we don't care who's on. We just want the numbers. Is it growing?
Right.
And likewise with respect to methadone. By the way, you'll remember on Director Squirrel's list of those 6 or 8 projects, there was a mobile methadone project that was already priced out on her list of things.
Right. So that could be something that you all could look at.
But I want to stop real quick with the mobile methadone. Probably going to lose my job saying this. These companies, and I might lose my job saying this, so that's not a joke. These companies make enough money off of Maine Care and the contracts that I feel that they should be able to fund their own van and their own, and then they're getting paid by Maine Care for each of these folks. So I don't have a problem with the mobile methadone, but I just think funding that, I mean, they make enough money where they should be able to buy their own, that, at least the infrastructure part. And then, and then they're getting paid through Maine Care and through, if that makes sense. That's just my opinion. It could be wrong, but I'm pretty sure I'm not. And again, I work at a methadone place who does this. They're multi-million-dollar organizations. So if they can't fund buying a van and setting it up, there's something wrong there.
Well, there's a lot wrong, Miles, but the fact is they haven't done it. So and it's a legislative issue. The legislature considered a piece of legislation that required us to do mobile methadone. And we asked, I think it was, I forget whose bill it was. And we asked them to withdraw the bill because we said we would do it. We said we will do it. And the idea is we will incentivize just the infrastructure, and then absolutely the sustainability. There'll be no ongoing costs. That would be expected to be taken care of by Maine Care and the uninsured contracts and commercial insurance. So I hear you, but I just wanted to respond that quickly because that is why, even if we agreed with you, we're kind of obligated through our legislative communications to try to do something in that area.
No, and I get it. I just, for the purposes of the state, is different than this council's fund, as I guess is all I'm getting at.
Yeah, no, it is. And we will constantly come up to this issue of nonprofit organizations, for-profit organizations. OBH has gone through that. Some of our RFPs were only for nonprofits. But when we came to the catalyst for actually capital, that, like, for instance, gave us new beds, both residential and detox at Pine Tree. Well, they're a for-profit organization owned by investment people. So I honestly, I just want to get the service provided, a quality service provided at a price or a cost that either we're covering or that the people who need the treatment can afford.
And the council could fund, because I don't know if there are nonprofit methadone clinics in Maine. There weren't back. Well, Acadia was the only one that did it back when I was.
Still is.
And back then nobody would do it. That was nonprofit because we begged people. But you could fund the harm reduction and plus buprenorphine. You guys could do some other model, right? That didn't ask a for-profit organization to. If you think that there are places in the state that where mobile, I mean, that was one of it's further down the list, but that is one of the things that you guys identified. So
yeah, Chastity.
From the testimony too, there is a separate request for a mobile program from Maine Family Planning if we wanted to look at different types of mobile programming that probably doesn't include methadone, but includes lots of everything else, from primary care to harm reduction services. And I think at a really low number for what they needed.
Yeah, that's because they got the van donated, but don't have the operational costs
right
to run it. So we have been involved in that project, Chastity. Yeah.
So just to keep us moving, I think, Miles, like what you just mentioned and what we're talking about, we'll capture in this grid that Kim and Mary have put together, because we're not going to get but I think you make a good point, and we just need to call that out, that infrastructure, and what the council thinks about paying for those sort of startup or infrastructure costs. But can we keep moving on to prevention? And as I said, Kim and Mary, we can sort of kind of add to the data, the grid that you guys have developed with what we're learning today. And I think I'm also trying to track sort of homework. So let's move into prevention if you are okay with that. And let's talk about BAR. Anyone want to kick that off?
I'm happy to talk a little bit about it. So I Mary and I spoke with some folks at DOE, and what I'll just say for those of you who maybe aren't familiar with sort of why BAR over other things in schools, I guess I'll say that schools across the state are at various places for what they can do to support social emotional learning and behavioral health of young people. I think some schools are further along in creating tiered systems of support. They call it multi-tiered systems of support. Tier 1 is universal. They're doing social emotional learning. They have positive engagement with students, good climate and culture. Tier 2 is working with young people who are having trouble, like need more skill building to help them be a part of that positive school climate. You know, they might have behavior issues that are coming up. Tier 3 would be young people who are really having lots of hard times and need more individualized services. So that might be like they need to see the social worker on a regular occasion. Schools have been trying to switch to this multi-tiered systems of support for a long time, and it's very difficult work. And if you just add social workers into the mix without creating this tiered systems of support, those social workers get totally overwhelmed really fast because you aren't catching young people in the tier 1 and 2 spaces. You're just sending everybody who has an issue to tier 3, and that's social work or guidance, or, you know. And so the DOE has said they have a pipeline grant to work on building the workforce for social workers in schools, because there are schools that have social work positions, but no one to fill them. So I think there's a desire to increase schools' ability to have supports for young people, but there aren't people to do the jobs. So how about we do infrastructure work, right? Like, how do we help the schools build an infrastructure that is going to really support young people across time and across risks? And I think the BAR model is especially good for young people who are furthest from opportunity. So anyway, that's the idea, is that you're helping schools really jumpstart their place into this tiered systems of support, and being able to have social emotional learning programs be a part of a whole system within a school, as opposed to a program that ends in 2 years when no one's there to do it, or it drops off someone's radar, right? It's a system. So it's like infrastructure. So they have money for first year. They had, you know, you can see there, they have money for part of the year 2. They need $800,000 more to cover those 71 schools for the year 2. And then they have no funding allocated yet for year 3. And that would be to have 71 schools move to the model. And they also have additional schools in Maine that are already on their way on the model. That's my spiel.
Of hands raised.
And Gordon and then Pat.
Well, I will begin by giving the same kind of caveat that Miles did. This would probably cost me my job, because I work very closely with Commissioner Macon, and I spent an hour with her a few months ago talking about BAR. I'm not there yet for the following reasons: that it is a great evidence-based program, don't get me wrong, but it is not directly related to substance use disorders. And the skills that they are working on, it improves graduation rates. It helps kids stay in school. It helps kids deal with anxiety and mental health issues. And there's no doubt that it has some impact positively on our issue, but not directly enough, in my opinion. But I could be convinced differently. I also kind of disagree with Liz that well, let me say this. I always describe this as a three-legged stool. This prevention work, the department, the education, the schools are incredibly important, but they're just one piece of it. They are actually not at the place where the kids that are most at risk. They're not even in school. And I'll come to that. So the second leg is really the Maine Prevention Network. That's our traditional programs funded by, at least by, have a lead contracted prevention program in each of the public health districts. Liz, fortunately, I think has the contract, her organization for Cumberland County. And they have subcontracts too, and that they do important work, but that work is also in tobacco, alcohol, lots of things, but they increasingly do important work for us. So that's the second piece. The third piece is what I'm most interested in, and those are the youth serving organizations that are in the before school and after school and in place of school events. So we've been working with the Peter Alfond Foundation. They have a cohort of 20 organizations that are mentored by 3 organizations: Tree Street Youth, a rural organization led by this Don Carpenter, and that's really more about mentoring, a lot about mentoring. And then the third group is Out Maine, and they are trying to grow capacity in these smaller organizations that get only $30,000 a year to do what they're doing. And it's organizations, Todd, you may be familiar with the Mid-Coast Youth Center in Bath. Tree Street Youth is in Lewiston. Trekkers is in Rockland. In my opinion, these are the people that we know we can identify the youth at risk. This is in my opinion, the most important thing the state can do in the long term is to delay that first use and to have fewer people start down that road. I learned this from Liz Blackwell Moore. Go way upstream and have fewer people start. Once they're in the people that Keena and our treatment community are with, we love them, we help them, we want them to live, but it's a really heavy lift. A little investment, in my opinion, with some of these 6-year-olds and 9-year-olds who are in difficult situations would go a long way over the long term. Prevention never gets its due because we don't see the immediate results of it. But these organizations are doing incredible work. And I think in the money that we set aside for prevention, there ought to be some support for all 3 of those legs. I've said more than I should probably.
Thank you, Gordon. Pat, and then Liz.
Mute. You know, I'm listening, but one of the things that when I see this, I bring myself back to my old job as the lowly substance abuse counselor in a school system. And when you're stuck in a building and you're the only one in the building that gets it, it's really hard. And so if you just stick social workers in a building, it becomes very difficult to change a culture. And that's what you're trying to do. You're trying to support kids from all ages. So there's a part of me that really likes this. There's a part of me that gets Gordon's piece of it, that there are kids at risk. This program helps. My issue is I get concerned about sustainability. This is a lot of money. And are schools truly invested in making this work? Or is this upper commissioner level saying, I think this is great, and brings it into the schools and said, this is what we're going to do. And if you don't have staff buy-in, if you don't have that commitment to everyone there, does this become a lot of money invested in something that isn't sustainable financially? Because it's a lot of money for schools. I think it's great. I think we need to support the schools. I think we need to support the kids. If we have this many people that are dying of drug overdoses, you've got so many children affected by this that are sitting in classrooms day after day after day, with teachers who aren't trained to know even what to do in regards to the trauma of these children. Again, I support it, just have concerns about the money, the buy-in of the schools that are doing this, and sustainability.
Thank you, Pat. Liz, and then Kim.
Well, I'd love to just kind of work backwards. One, I'll say, Pat, to your point, I too was very concerned about that, and it's always a concern of mine. But I have worked with some of the schools who've done bar here, and they love it so much and are super dedicated to it. And I know that DOE put out a call to schools to see if anybody wanted to do bar, and they thought they would get 10 schools interested, and they got 84 or something, and they had 71 who signed up, and they've had 20 more that after the deadline saying, wait, we want to do it too because we've heard it's been really great, and they haven't been able to been able to add them to the cohort because they don't have any more funding for it. So I think there is great buy-in because there's been so much talk and so many programs thrown at schools, like do this SEL program. But programs are not systems and infrastructure. Programs have a hard time lasting. Infrastructure does. And so I want to say that, so I'll go back to Gordon. I'll say that I agree with you. I think youth serving organizations, like those organizations, I've worked with some of those organizations, they're incredible and they are doing great work. That wasn't chosen by the group. And so one of the recommendations I actually have for us is that we were our task up front was to prioritize things that we could spend money on this minute. And I think there are things we could spend money on in prevention this minute. And that I also would like to propose that we have a prevention work group that works with folks in prevention to come up with some key things that group recommends to the council for long-term funding for prevention. Because I think there are things in the Maine Prevention Network that I think they would love long-term funding that's sustainable, that they can count on, because a lot of the money is federal funding. It's very specific. So to have money that's a little more you can use to address the particular needs, I'm all about that. I think that, so I'm agreeing with you. You know, I would spend a ton of money on prevention if I could. But I also do think that all of the things that the bar system is working on, that is absolutely prevention. Like we need to see prevention in this bigger way, and that having young people have protective factors and relationships in school, out of their homes, in youth serving organizations, especially those kids who have the least opportunity and have been most impacted by substance use disorder, they will benefit the most from a school structure that works well. And I do also agree with you that there are young people that aren't in school. And so we have to think about other programs and other work for them. That gets me to the flexible funding for wraparound supports for kids who are in foster care. That's my other thing that we've, who are in foster care or who are, have been, that Muskie has identified as young people who are disengaged. We know I know there are 2,200 of them in Cumberland County. What are we doing? Like, we should be targeting them, but I don't know that we know exactly this group. I don't think we have what's the thing we should do. So that's why I'm suggesting we can fund some things in the short term, like bar. They need money this moment. They have buy-in, they have schools ready to go. And then also we think about a long-term plan for prevention, because you have to invest in it up front. So sorry, that was a lot of words, but thank you.
Very good, Liz. Thank you. Kim.
Okay, just a process note. This is what you picked already, right? Like, I would not recommend revisiting this, but what we could do is go back to the Department of Education, because I thought originally what you were talking about was adding schools, but what the department has proposed is for you to continue funding in the second and third year of schools that they've already funded. So we could go back to the department and sort of ask, why didn't you fund the third year? And maybe Gordon, you already know that. And come up with a different dollar amount or a different kind of a plan, right? Where it's not where you're not feeling like you have to give 4 million of your of a year's, so we could do that, but I would not recommend revisit for the short term, revisiting your selections, right? Because it's been a process. You guys chose it. That was the number one voted thing, and the number two thing was the flexible funding.
Well, the only thing I have to add is that this bar program, my recollection is that the schools pay an amount of money for maybe the first 3 years, and then it's sustainable. So that's the good thing, is that it's not an investment every year, and that they're paying for staff people to teach their staff the model and stuff like that. And yeah, I mean, it is, and I mean, like I say, I think we have some real choices there. The thing that I like the best idea, honestly, is letting a small group of a subcommittee work on prevention and get some prevention specialists in and see. I'm going to keep pushing for those youth serving organizations, because I think they're the ones that are working with kids at risk and really really doing some extraordinary work. And to them, $10,000 is like $1 million to the Department of Education. But it's all good. I think we're all committed to doing a piece. I don't feel, Kim, honestly, I think it's okay to revisit. You've said at the beginning of the meeting that this was kind of rough. This is a rough draft, and that we should be able to, at the next meeting, solidify it once we see how it all lays out. Again, I was at a disadvantage being on remote, so I think people shouldn't feel wedded to until they see the whole piece. That's just my opinion.
I think that's okay. I mean, I feel the time pressure, and also just understanding that these are not, like in this one in particular, which I have no skin in this game, but this one in particular is a potentially one-time thing, right? Coming out of the one-time thing instead of the ongoing thing. So, and it was the number one thing in prevention. But again, it's your process. What we could all get caught up in this sort of continually changing our minds thing, or trying to convince each other to change our minds. And I don't recommend you do that.
Todd, you had your hand up, I think. Are you? Oh, we can't.
Mute.
Yeah, there's some.
Is he frozen now?
Yeah,
Yeah, you're good, Todd.
sorry about that. That's my end. Every once in a while, my speaker microphone dies out. I'm gonna have to switch. So I would just no, just a couple of quick observations. I supported VAR, for example, because it was the only early childhood educational program that was presented to us. You know what I mean? So I see the benefit of that. I don't know a lot about the program otherwise. I am interested though to find out, as our discussions unfold with DOE, they're going to get some of this money, right? What's their plan going to be? With
They
their
have to use, but they have to use the education money it has to be used for special education. That 3% is special education dollars. It's very separate from this.
All right. Well, I didn't realize that. I apologize. I probably read that a year ago when we first got the document, but I apologize for that. So.
Yeah, Todd, I just realized that too. It was somewhere, and it was pointed out to me that it really, about a month or two ago, it is special ed dollars only.
The last thing I'll say is, as a guy who's married to a 34-year juvenile probation officer employed for DOC, I think supporting the schools are important. I wish there was a program called PAR, not just because I'm a golfer, PARR, for parenting assets. I don't know how we bridge that gap, but the schools aren't parents, and until we can do something there to support parents, educate parents, give these kids that influence.
So can we transition to the flexible funding one? Because
Yes,
I think
go
this gets
for it,
into
Liz.
that space. So I think there was some conversation about how do we what are two generational approaches to prevention? And so there are programs that are coming back. So we had a lot of two generational programs for parents. We had parents as partners. We had whole family coaching. We had a whole bunch of projects that Joe probably could speak to better than me at this point that Opportunity Alliance did, but a lot of CAP agencies did across the CAP agencies or the community action programs across the state, who had a lot of two generational things that were funded for often for child abuse and neglect prevention, but they are also incredibly impactful and effective at supporting, and building protective factors and reducing risk factors for young people for substance use disorder as well. So those programs already exist and they're kind of coming back. And I talked to some folks, and I think there was this understanding that more and more of those programs are getting funded again that use whole family coaching, that has a lot of good evidence for increasing protective factors for families, and it's wraparound supports, Todd, for families. And it includes not just like parenting skills, but it's also supporting people to get their basic needs met. And we know that people's basic needs are not being met, and those have to happen in order for there to be people to have stability. So the flexible funding could be, in addition, could be accessed by people who already are involved in one of these whole family systems coaching programs that the Office of Family Independence already funds. So that's one avenue. They already have it at the, Opportunity Alliance has a flex fund. So does the Washington County, the Community Care Collaborative has a bridging program that then they do flex funds with it. So people can access it for a car repair or a rent check or a medical bill, like things that knock people completely out of their shoes and back into, either homelessness or substance use or, something like that. So it's an option for how to fund something like this, that we know when people have financial security, they have better outcomes, and then their children have better outcomes.
So just to keep us moving, yes, thank Liz, that's great. And I think that flex funds are like critical, and I think we need to inventory a little bit more of them. So there's the mental health wrap fund. So TOA manages 4 counties. So like that's a lot of money that, I think there is. So if we could work on that. I think, Liz, what I really love what you suggested, sort of the prevention, a prevention work group. Like if we're going to dole out $5 million, you and your colleagues have a lot of good ideas. So as much as I support BAR too, if you got $5 million as a network, so to speak, of prevention experts, I think thinking about how the money could be spent or would be spent is a worthwhile, exercise. But I think we can, again, we'll keep adding this information to gather more information, gather more facts as we move through. Because I think BAR is not an easy decision, because it's a fair amount of money. But we'll gather more information. Okay, so let's keep moving right along to harm reduction. Anyone want to weigh in on the harm reduction top couple of suggestions?
Well, I think that I spent 90 minutes with the syringe program yesterday, and what I would like to do is they are in existence. They are doing the really incredible, difficult outreach work. OBH has one program where we're supporting, I think, 9 peer outreach workers with lived experience tied to a couple of those organizations. There's 9 of them. We probably need 90 of them. They don't have very much flexible funding. Their funding is very tight, what they can spend the money on. And they've never had much money to do outreach to. They are the ones that are in touch with people using drugs, at least the people using drugs who are not interested in sharing needles. And I think that there's about 16 sites, there's maybe 23 certified sites, but they're not all operating. But I would love to offer them money for outreach to people who are using drugs and are at obviously the most risk of dying and not having a chance for treatment when we get these beds up. And you know, you could do it, I think, pretty simply by offering it to the certified programs and ask them to say we'd like to help them reach more people and do outreach and keep more people alive, do all the things they're doing, but do more of them in more parts of the state, and offer them up to, say, you know, I don't think we ought to do anything for 1 year. I'll be honest with you. It's just too much of a lift for these little organizations. You know, offer them up to $100,000 for 2 years, $50,000 a year, up to, if they submit us a budget and what they would do with it. You know, a simple page. I don't want to see I'm trying to keep this. I think it's the most significant thing almost that we could do immediately to get people on. They still have to hire people,
Right.
but that would be so meaningful to them. And I would frankly, on what supplies they could buy, I would simply kind of nuance it and leave it. The less said about what they do with it, the better, as long as it's legal. And so that would be my idea. And while we're getting more nuanced in our harm reduction, in the meantime, we can think about other things. But we could do that right now, and it would mean a lot to them.
Ditto, ditto, ditto. Good. Yes.
So do you want us to put that in the spreadsheet, a proposal of $100,000 per existing SSP? And what about adding new ones? That was one thing that
Existing site,
Yeah.
Per site,
yeah,
per site.
because then
That's a
you could
good site.
have, you know, one place they have multiple SSPs, but they'd only be eligible once. I'd say per certified site.
Yeah.
yeah, you can't imagine how helpful this would be. We have a place today that has run out of needles, for instance, and because
Been
the
shut
state's
down for
because of
a
the state
month.
because the state is late with its payments. I mean, honestly, this kind of help that would be flexible. So I mean, if they need to buy needles with it, fine. If they need to buy other supplies, fine. I mean, keep it as flexible as possible, get it out there as soon as possible, because we wouldn't have to worry about eligibility. We would consider anybody that's certified by the CDC to each site as being eligible. I don't want to determine what the amount is, but I just throw that out there that's a meaningful amount of money. Not all of them would probably apply for all of it, but if you there's about 16 operational sites in my opinion. So if they all did 100,000, is that 1.6 million? Is my math right?
Over 2 years, though, you're saying, so.
Well, I was going to spread that $100,000, $50,000 a year. But again, I think we haven't gotten to the point of talking to Deputy Commissioner Mann about how much, and the Finance Committee about how much of the 20 million that they are right now, with more coming, I believe, before the end of the year. You know, probably the AG's office will weigh in on this and scream at me, but we should really have as a threshold issue, Joe and Kim and Pat, I think at the next meeting. Okay, what's the Finance Committee recommending for how much we could spend in the next 3 months? Let's say, what are they comfortable doing? Because we know Ben is financially going to be concerned that we don't spend the cupboard bare if we're going to continue some existing obligations. We'll never have more money. Well, I hope we will, because I think the Purdue thing will get settled and there'll be a couple more decent sized settlements coming in down the road, so that 260 million or whatever will grow. But right now, it doesn't look like we'd ever have more money than we have right now. So we shouldn't spend it all.
Well, Ben shared those models. Gordon, I don't know if you were on at the meeting when
Yeah,
he
I
was
was
doing that
on
video.
remotely. I've seen Ben's models. Yep.
Yeah. So I think Ben has a good grasp of Gordon, to your point.
But it also seems like this is one we all agree like needs to be done, and like can we just do it? And Chastity, is that the right amount. And Tina, is that the right amount? I feel like you two are in it.
Yeah, I was just wondering what Chastity thought as well, but I'll just jump in and say, like, I do wonder if we should do at least like 150, like per site. I mean, just thinking about like staffing, I'm only saying this through Project Dharma. We're only able to pay for part-time help. And we know that this has been really successful, but like to hire someone full-time plus get enough for like $50,000 for smoking supplies, other supplies, it kind of adds up. So I'm curious what Chastity thinks too.
Yeah, well, that's why I kind of pushed on the per site instead of per organization. Like for us, for example, we have to fundraise $50,000 for a year just to pay for smoking supplies alone.
Sure.
So, I mean, obviously, if we could do more, I think every program
Yeah.
can use it and find a use for it.
I mean, we spent $30,000 alone on like wound care supplies.
Yeah.
So
Yeah, I mean, I think honestly, I wish you'd talk more about wound supplies and just, you know, keep it as flexible as we can.
Yeah, I mean, there's lots of opportunities. That was
Yeah.
just an easy number that I knew right there. So I
I mean,
think going higher to really focus in on everything, looking at testing, wound care, all of the peer support that's done, like it'll be used. You won't have programs that'll have to shut down because they have no supplies and they can't provide what their community needs.
So you're talking, if you gave $150,000 and there's 16 sites, that's 2.4 million.
Over 2 years, you're saying, so.
Is that the 150 for a year, or is that 150 over 2 years?
2 years.
Okay, so that'd be over 2 years, it'd be approximately 1.2 million a year that you would give to the 16 sites. That's the sites, right, Chastity? That's not the original organizations.
Right.
And it seemed to me if you could write up a simple RFP or a simple thing, and they submit a budget, and then just have some outcomes that we'd need. For instance, we'd need to know how many people they serve. We need to know certain things in order for us.
They report all that, Pat, they already file
Yeah.
now monthly reports to the CDC. So we know exactly how many clients
We'll just in our report match that. So they're not keeping different numbers that they're keeping. As long as they're keeping the numbers that we want, we can match those. So you're not creating organizations with, please, no more data, separate data.
And I am not certain that all the sites, you know, you have some big sites and you have some very small sites that are fairly new. I'm not at all certain that the new sites, for instance, would all necessarily jump at this and apply for the whole amount. So I think that the total might well be less than the 2.4 million, but I have a trouble getting my hands around that number only because we haven't seen how much we're doing for prevention, how much we're doing for treatment, how much we're doing for recovery support. We haven't even got to that. So, I mean, I do think this is impactful. I think it's immediate. I think it's the most important thing we could do right now to actually save lives. So the sky's the limit as far as I'm concerned. And I think it's the rest of you that will need to say, well, what's fiscally prudent here? But I don't think you should assume that every single site is going to apply for every dime of it.
The other thing is finance meets on Thursday.
Oh, good.
And so if we think it's a recommendation from this group that we asked finance, are you going to indicate how much money per group that you're spending? Or can this committee make a recommendation? Again, are they going to do, you know, 2 million per, and I'm just throwing out a number, 2 million per prevention, harm reduction, treatment, or are they going to do it as needed and not, I don't know, is it going to be distributed equally or not equally amongst the areas? And if it is, if we can get that number, it'll make it simpler for us to make the decision. So I can bring that to the finance committee, the concern if that's what's agreeable.
Pat, would it be helpful? So I have the finance committee meeting in my calendar too. Would it be helpful to share this spreadsheet with them so they know what you guys have discussed today before they meet?
Yeah, I think so. We can get Mary, if you could do that and make sure that they have your spreadsheet before the finance committee. And just say that, well, we can talk about it later, but the grants committee would like you to see this as we start to think about budgets and money.
I
Can
don't
I ask-
actually, I think it wouldn't hurt to send the entire council the spreadsheet, Kim. I mean, I guess
Okay.
that's all of us, probably if you send it to the two groups, but I think it's really clear.
It's so drafty, but,
Well, it's
but,
pretty good.
like,
I
would
think
have
it's
fixed
good, though.
typos and stuff, but,
That people know the content. But Keena, are you waiting for a question? Sorry, I'm trying to
Oh,
keep
yeah.
us going.
Oh, that's okay. No, I was just gonna say, just to reiterate that, yeah, if we keep the funding flexible, because the other thing I'll just add is like, we haven't been able to cover mobile units or like for the organizations to do outreach with any of our grants, harm reduction grants because of federal limits. So, just to take that into account more.
Great. Okay, Todd.
Can you hear me okay?
Yeah.
Sorry about that. So I don't know if I should even ask this question, right? So I'm going to ask it, but is there, and I don't want to offend anybody, but is anybody concerned about the optics about whatever our first funding is, what the optics are going to be like publicly, right? I'm all about what you're talking about. Don't misunderstand me. I support harm reduction. There's a lot of people that don't understand it. There'll be a lot of press around it. I'm just wondering, there was a bunch of other low hanging fruit things as we consider or make recommendations maybe to finance. I'll be at that committee meeting as well. I just throw it out I don't want to spend a lot of time on it. I'm just concerned about what the optics are.
I guess I would like to respond to that immediately to say that I would feel really proud to be on a council that said it was valuing human life first, and that we were saying this is money, this is blood money, and we're using blood money for supporting people who have been most impacted. And I think that I think the optics are that we are against stigmatizing people who use drugs. I think we could come up with some really great language about why we think this is so important as the first thing that we do, while we're also thinking about prevention and setting up treatment for folks as some of them become want to choose that option, that we are doing all of those things, but we are also very much investing in people in harm reduction. So anyway, I'd be psyched to do that.
Thank you, Liz. Bruce.
I guess I'm just going to reiterate what Liz just said. I mean, for me, it would be a source of pride. And I think also it serves as a kind of a message of education to the public that if we chose as a council to fund this first, then this is a thing. And if you're not behind it, then you're behind. Like, you've got to get behind this. This is, and the state's been doing this. The governor's been doing this since the day that she got there. That's what Gordon's been doing for all this time. I think it shows that we have our priorities in the right place. And I would be proud if this was the first thing that was funded. And I think it is the lowest hanging fruit. It's something we can do right now. And I hope that we don't lose this momentum that we have right this second.
Thank you, Bruce. Gordon.
Well, I kind of agree with all three of you, including Todd. I don't see any reason not to pair this with some work that we are committing in prevention and treatment and recovery support. So, this is about decreasing stigma too, and we want to win the hearts and minds of Maine people. So I hear you, but I also don't think it doesn't make it any less impactful if we also say, oh, and we're doing this in treatment. And I remind you that when we talk about flexible funding, we're also talking about people doing outreach, people using drugs, and also the ability of them to refer people to treatment. So it's, we can be smart and we can work with the Attorney General's office and our communications people with putting forth the correct message. But I don't disagree that that we should be proud to be trying to keep people alive and trying to keep them, but also there's nothing wrong with them also joining the 3/4 of people in America who are in sustained recovery.
And I think it's very important for the public to see us deliberating. I think people are watching us right now. They will watch. I think this will be deliberated at the full council meeting. We're making recommendations. So Todd, I'm thinking that what you just said in every way, everything that we spend on, I think is going to be, there's going to be a reaction. So I think just the way that we're observed, making our decisions is going to be really important. And it's 4:25. We haven't yet got to recovery support. Do we want to take a moment and just talk about recovery supports?
Yeah.
And if anyone would like to jump in with thoughts around the two highest voted groups.
What were they?
And remember,
what were
remember the second one is like, I just made that up because you
So the
didn't really have
recovery
a
centers,
high.
Gordon, I'm sorry, Kim.
Oh, yeah, the first one.
Recovery
Yeah.
centers, and I think
Recovery
Gordon, at the
centers.
end of last meeting, you were on the call and maybe you can just speak a little bit about where they are, the recovery centers, and if there's any intel that you may have.
Yeah, well, there's 22 that have applied for funding in the new tranche of 2 years of money that we have. Those are being scored. There's a lot of work associated with that because they're really not competitive. We would hope to give some money perhaps to all of them. There's at least one in every county, although there's really none except for Piscataquis County. There's at least an application for one for Somerset County, and hopefully that would get funded. So there's 22. We would hope to have one in every county. There's still room for more, but I think the real need there is sustained. We're going to help them for a couple more years, but there really is no sustained plan for where this money will the state really be able to continue at a robust level to fund that many recovery centers. So I think the Recovery Council may need to be in play there a little bit. But we also have recovery residences where we have some counties that have like 2 recovery residents. In Washington County, there's 1 with 5 beds for women and their children. I mean, we need to incentivize, in my opinion, more recovery residences. And then the only other 2 recovery activities are really recovery coaches, recovery, we got recovery centers, recovery residences, recovery friendly work sites. We've got that program going. But I would say the urgency, honestly, I think is recovery beds right now more than recovery centers, because I do want to do more with the recovery centers, but right now I think recovery beds in some of these rural areas where we have no place, and the transitional bed issue is huge. What Ron Springle said of when people have to leave a home because their use has recurred, and then they have no place to go. And so a couple transitional houses to incentivize a provider to do something there, it's almost akin to housing first. To say, okay, you didn't, it takes people 7 times on average before they get into long-term sustained recovery. So we need to understand that as we build out our system of how we're going to keep people alive and give them every opportunity for success. So I think the transitional idea, housing idea, and then in those rural areas where there's no recovery residents right now in Piscataquis County, for instance.
Yeah. Pat, Miles, Bruce. Oh, Pat, you're on mute, I think.
I am on mute. So recovery residents, there's no recovery center in Piscataquis County. There's just the cafe.
Just the cafe.
Okay.
I am meeting with them tomorrow morning to look at a site in Sangerville, but right now there's nothing. It's just the cafe Wednesday morning and
Okay.
in Dover Foxcroft.
And the other piece is it'll be interesting to see. I hear a lot about people leaving jails with no place to go, in trying to go back to their community where they live. And so there's a real concern of mine in recovery supports for residencies. If you talk to Maine pretrial workers and everything, they spend days trying to find people that are leaving our county jails a safe place to live. And so I would support that. And I think we could do something there quickly, also in getting that funding out.
Thank you, Pat. Bruce?
Yeah, so on the recovery centers, I'm sitting in a recovery center right now, but I totally agree with other folks' sentiment that we need more recovery residence beds, more than, I'd love to have more funding for this place, but obviously the RFPs are out. And I think I've probably said this before in other meetings, but recovery residences are our de facto halfway houses for the state of Maine. We have no halfway house system for prison. We have no halfway house system for jails. And just like Pat said, when folks are leaving jail, when folks are leaving prison, when folks want to enter a treatment court, if they don't have a place to live in that particular community where the treatment court is, of course, they typically don't even have any transportation either. But if they're going to that community and there's no place for them to stay, then they can't go into treatment court. And folks end up either languishing in jail, waiting for something to happen with the treatment court, or they're in the community and they're continuing to use. So I just see this as a huge priority. The more recovery residents, and I'm calling them recovery residences, not sober houses or whatever. I'm talking recovery residences. Maine Association of Recovery Residents certified beds. That's what we need. And I'm talking from an organization that, that assists hundreds of people that are getting out of jail, hundreds of people that are getting out of prison, dozens and dozens of people that are in treatment courts. We need these beds like years ago.
But we could incentivize in those counties that have none or have fewer than 3. I mean, we know we need them in Washington, Aroostook, Piscataquis, Somerset, Oxford, particularly. And just incentivize people to buy a house, get it up. It doesn't require a license even. And so there's a lot we could do there. And in addition, we could subsidize the beds like we do already in a state program. But the other piece is, it's not just the building. We need peer support specialists to be with the individuals in the jails, as Bruce organization does in just 2 jails, Kennebec and Androscoggin. We need that in 16 jails, and we need them also to be helping people in the recovery residences. So I'm a big people with lived experience. They are the ones that are have credibility and can help people. So I think that's an important piece.
Could you do something like you were saying with the SSPs, where you did some sort of flexible funding with the recovery centers to hire new staff to do specific things, or something like that? Because you have recovery residences is also on the list.
I think, yeah. So you're saying that for the recovery centers to employ more peer recovery supports, is that what you're saying, Kim?
Yeah, I mean that was the thing. I mean, it got, I think, more votes than anything else on the list, 6 votes. So yeah, are there specific sort of activities or groups, or just even making it flexible funding like you had talked about with the SSPs to support more outreach?
Yeah, I'll just say what we do here at the Augusta Recovery Reentry Center. This building is where all of the peer recovery supports that work in the jail are centered. And that can happen in places that have recovery centers, but we're also talking about places that don't have recovery centers. We're talking about the rural, and I know that we've mentioned this as kind of an overarching theme for what we're doing. And I really appreciate that Gordon mentioned these rural communities that don't have enough recovery residences. I just think this is the recovery residences and thinking about rural areas and all areas, but really getting our focus on these rural areas, because the folks that we work with that are getting out of prison and jail, they end up typically only having a choice to go to a service center. They can only go to Lewis and Auburn or Portland or Augusta or Bangor, because that's where the services lie. and they can't go back to their communities, or at least familiar, semi-familiar communities, because they have no choice.
And while treatment facilities are really a big lift and take, you know, in the case of Wellspring and Miles Spring, almost 2 years from award to opening the bed. These things are, you find an old house, fix it up, you get, the staff can be anybody. I mean, yes, we want it certified, but because they're not licensed, and then the certification is not a high barrier. And the laws are quite favorable now with respect to fire protection systems and things like that. So I think to incentivize someone to find these locations in those 5 or 6 counties that I noted would also be huge. And then if you want to tie in the recovery centers, give them a program that where they reach out to the local jails and provide more peer support through the recovery center for the jails. That's how we could be true to our preference to help the recovery centers, but it would also direct it to the people that are most vulnerable, which are people recently getting out of ready to get out of incarceration.
Miles,
I wish you, you know, I know Lincoln County often gets forgotten, and it's because it's close to my heart, right, for obvious reasons. But don't forget us down here on the coast. We have a fledgling recovery center, just trying to get its legs under it. We have no residential situations like you're talking about. And maybe our need isn't as dire, or our county certainly not geographically as large as Oxford, Piscataquis, and the others, but you know, we're still a long ways from here to Portland, Bangor. It's only 30 minutes to Augusta, but
yeah, I think you're right, Todd. You've got a recovery center because we opened it the other night in Newcastle, but I don't know that you have a recovery residence in the whole county. I don't think you do. So that's something to think about. Sure. I'll just tag Lincoln that after I say Oxford, I'll get used to adding Lincoln at the end of that.
I also think we like there's some models for this that then you can get sustainable funding from, or not sustainable, but you can get more funding from the federal government once you set up, you know, a partnership between the jails and the recovery recovery resource centers and recovery residences. There's some models.
There's a business model in opening up those beds, that if you start them up and you work them, you can keep them afloat. But it takes startup money, and it takes something. Scott Party at Fresh Start has done it for a long time. There's ways to do it, but they need help to get it started.
But I would love to see this incentivizing piece for people with children. I mean, we're missing a whole group of women and people in general with children.
Remember, we got the federal earmark, though, for $15 million for 4 Macaulay residences in the rural areas. So if that flies, that is a game changer. But but of course, it's not done yet, and all these things are problematical. But I'll give Senator Collins a lot of credit and mercy that you know, that's $15 million for women and children in Macaulay residents, and maybe one for men and their children would be helpful. And if that doesn't happen, then we need to backstop that. Yeah.
Okay, Miles, you had your hand up, so I'm gonna.
Yeah, no, no, I'd like to see some data on some of these recovery centers. I've been to almost every one of them in the state of Maine, and I know some of them have more frequent flyers than others. You know, you've got the Barn, you've got PRCC, Augusta, but I know in terms of sustainability and how much money we have, I'd like to see some data on these recovery centers, because I don't think they're sustainable. There's no business model behind them. We're always going to have to be shelling out money to them. So, and they do a lot of the same things as some of the treatment centers or treatment programs do. I feel like recovery residences, there's more of a business model, more sustainability, more of a need. So just to piggyback on a few other folks, but I don't want to say I'm skeptical about the recovery centers because they are, they've done some amazing things, and some of these bigger organizations do some amazing things. I just know I've been to a lot of them that are dead, that they don't have people coming through the door. So how long can we fund these places with not many folks coming through the door? And there's other places where they can go to get resources and those kind of things. So that's all I was getting at, is sustainability, how much money we have, and where the best option should go. And I feel like the recovery residences are the way to go.
We have recovery capital data. I've been to every one, Miles. I don't disagree with you that they won't all make it. They won't all make it. But where there's a good, strong local support for it, and where we're doing 12-step meetings and recovery coaches, where our recovery coaches meet for to coach people. I mean, the barn's a beautiful example. It has saved people's lives. So I want 22 barns. But again, we won't get there in every case. So I'm not really disagreeing with you. I think almost everything we've talked about, it's none of them are perfect. And we're going to have to evaluate and make sure that our money's well spent and well placed. But we have talked about a number of things that could really, in a short time, I think, make quite a difference.
On that, that's the last word. We're 10 minutes over. What I would say or throw out there is the idea of maybe meeting one more time before the full council meets, if people can do that, because we really need to now, I think, revisit the conversation after we get some more information. But I also think a big piece of the conversation needs to include the technical assistance aspect for potential bidders and also or programs, and also just the procurement process. There's compliance to this, and we're not a state office. To Gordon, you kind of mentioned some to that point. So I think we really need to talk about, as we think about getting money out, how will that happen through procurement, and how will we track data and outcomes, because we don't really have compliance staff, which I think will be equally a lively. Today's been a great conversation, but I think now the nuts and bolts, well, we're not even to the nuts and bolts, but I think we need to move ourselves to the nuts and bolts of the procurement process and how that's going to look. So are people available to meet another time before we meet on the 14th?
You just
Yes,
have
and
The only day that's possible is Wednesday the 13th. So I would
Yeah.
need a draft agenda by tomorrow to notice it, which is like totally possible. I just wanted to say that's the option.
So let's do it.
yep,
Same time, 3 to 4:30.
Sure.
sure.
All right. You guys are easy to work with.
Joe and
Okay,
Pat,
that's
you want,
great.
can I talk to you later
ahead.
about like what you want from me to make that conversation easier for you?
Sure.
Because we could also come up with some options for procurement stuff too. if
That'd be
that would
great.
useful.
So
Just
Kim,
add
can we
to
schedule a
spreadsheet.
time tomorrow? I'll look at my calendar. Or it's sometime soon, but I think if we can begin to like sort of pull together today's conversation, and I think using the format, the grid, I think might help us to narrow it down and then talk about procurement.
Can you just repeat that meeting date? I want to make sure I got it right.
Wednesday the 13th from 3 to 4:30.
Thank you.
Thank you, everyone. Very, very good conversation, very lively, full participation. And we'll get information out to folks before the meeting, and we'll look forward to seeing each other again on the 13th. Thank you so much. Bye-bye.